Hi guys, today we'll move with the topic postpartum hemorrhage. Postpartum hemorrhage is a complication of third stage of labor. Postpartum hemorrhage is we can classify it basically into most commonly atonic and traumatic. Traumatic varieties due to uterine rupture, cervical tear, perineal tear, or vulval hematoma. It is an obstetric emergency, most common cause of shock after delivery. Definition: by convention, we say blood loss greater than or equal to 500 ml after vaginal delivery or greater than or equal to 1000 ml after C-section. ACOG says blood loss greater than or equal to 1000 ml or bleeding associated with signs and symptoms of hypovolemia. Coming to the clinical venue, a fall in hematocrit greater than 10% between admission and postpartum period, we can call it clinically as postpartum hemorrhage, or excessive bleeding needing blood transfusion. WHO defines severe PPH. Blood loss greater than 1000 ml is severe PPH. PPH is divided into primary and secondary bleeding within 24 hours at delivery. This is the most common variety. And secondary is bleeding after 24 before 12 weeks. That is between 24 hours to 12 weeks of delivery. As I said, primary is the most common variety. Primary is most commonly due to atonic PPH followed by traumatic PPH. Secondary PPH is most commonly caused by retained placental tissue. PPH can be due to most commonly due to uterine atonic and traumatic PPH retained placental tissue bleeding disorders like DIC. We can remember it with four T's: tone, trauma, tissue, and thrombin. Now, the risk factors for atonic PPH: advanced maternal age, multiparity, obesity, previous history of postpartum hemorrhage. In the present pregnancy, if the patient is having placenta previa, abruptio placenta, or uh, pregnancy-induced hypertension, overdistension of uterus. Conditions causing overdistension of uterus are multifetal pregnancy, polyhydramnios, large fetus, and retained clot. In the intrapartum period, there is rapid labor. If there is rapid labor or precipitate labor in a sense, it means the entire process of delivery happens within 3 hours. So the placenta, everything will baby will be delivered within 3 hours. So the tone of the uterus is not adjusted. So that's why it's a cause of atonic PPH. A prolonged labor, augmented labor, chorioamnionitis, use of general anesthesia and abnormal placentation. For traumatic PPH, the increased risk factors are instrumental delivery, high parity, tachysystoly. Tachysystoly means greater than 5 contraction in 10 minutes. Breech extraction, obstructed labor, management of PPH. Coming to the management, first we have to do the initial step, that is maternal resuscitation. You have to massage the uterus, put two bore IV lines of number 16, give 1000 ml of crystalloids, place Foley's catheter, and monitor urine output. Investigation for blood grouping, RH typing, and complete blood count. Arrange for blood and blood products. After this initial steps, you have to move on to the examination. That is per abdominal as well as per vaginal. Per abdominal should be the first and followed by per vaginal. In the per abdominal examination, if the tone is normal following PV, there is laceration or hematoma, you should be repairing and manage the laceration or hematoma or the trauma that is caused. If in per abdominal examination, the tone of the uterus is decreased or uterus is soft, or on massage, the tone increases and then becomes soft, then it is atonic PPH. You have to do a per vaginal examination to ensure that the entire placenta and placental membranes have been expelled. Now, after this, you have to give uterotonics plus tranexamic acid for 30 minutes plus massage uterus. What are the uterotonic drugs? First is the oxytocin. Oxytocin dose is 20 international units in 500 ml of NS. Do not give IV bolus or infusion with dextrose 5%. It is the first line of drug to prevent and treat PPH. Now moving on to methyl ergometrin. The dose is zero point 0.2 mg IM repeated 2 to 4 hourly. What are the contraindication? The contraindication we have to remember is stopper. That is twin, organic heart disease, preeclampsia, eclampsia, RH negative pregnancy. You have to give IV to severe hypertensive patient. Severe hypertension is also seen in patient with pregnant HIV who are using protease inhibitors. Now we'll move on to prostaglandins. Carboprost, PG, F2 alpha, Dinoprost, Hemdate, all are the same. You have to give 250 micrograms IM after 15 to 90 minutes. Repeat if necessary. Maximum you can give 8 doses. What are the contraindications? Absolute contraindications are asthma, pulmonary hypertension, suspected amniotic fluid embolism. Relative contraindications are PAH, renal, liver, and cardiac disease. So the success rate of carboprost is 88%. It is the drug of choice, not the first line. The first line drug is oxytocin, but the drug of choice here is carboprost. What are the most common side effects? Diarrhea, hypertension, vomiting, fever, flushing, tachycardia, and mesoprost. That is another prostaglandin. It is called as PGE1. WHO also recommends oral and sublingual with a dose of 800 micrograms. ACOG says 600 to 1000 micrograms oral, sublingual, as well as per rectal. Contraindication is dose-related hypothermia, previous C-section. So, comment WHO doesn't recommend carbitocin for management of PPH and dinoprostone. WHO doesn't recommend dinoprostone, but we may be used 20 mg suppository per vaginally or per rectally. Contraindication for hypotensive patient. Many patients can be hypotensive, so WHO doesn't recommend use of dinoprostone. It is not dinoprost. Dinoprost is another name for carboprost. It is dinoprostone. Tranexamic acid. Recommended by WHO for treatment of PPH given within 3 hours of hemorrhage. Dose should be 1 gram added to 100 ml of NRs infused over 10 to 20 minutes at the rate of 1 ml per minute. Faster infusion can lead to hypotension. If bleeding persists beyond 30 minutes and reappears after 24 hours, second dose of 1 gram is given. All uterotonics and tranexamic acid for maximum of 30 minutes. If it doesn't work, then we'll move on to mechanical methods. First, we'll bimanually compress the uterus. It's a temporary method. Then balloon tamponade. Foley's catheter. It has a maximum capacity of 80 ml. Bakri balloon catheter. It has a maximum capacity of 500 ml. So obviously, Bakri balloon catheter is better. And SP esophageal catheter, condom catheter. If the bleeding stops, remove after 12 hours. Success rate is 85%. If the bleeding continues, now we'll move on to the next step, that is uterine compression suture. Okay, the most common used is V-link suture. braces we call. Chromic suture of number 2, anteroposterior suture along the entire length of the uterus will putting the bleeding suture. In case of DIC associated bleeding, it is simultaneously corrected with blood transfusion and along with it we'll do bleeding suture. What is the complication of this bleeding suture? Uterine ischemic necrosis with peritonitis, uterine synechia, uterine wall defect. What are the other sutures? Cancella, Cho square, and Heyman suture. If bleeding still continues, you have to go for stepwise devascularization and angiographic embolization. First, you will target uterine artery ligation, unilateral or bilateral. So, this is the uterus. You see, the site is here. As the uterine artery turns upward in the broad ligament at the level of utrovesical peritoneal reflection. That is called as O'Leary technique. Care to be taken to avoid injury to the ureter because ureter lies very close to it. Uterovarian artery, anastomosing branches. If still bleeding continues, if vitals are stable, then you will be doing internal iliac artery anterior division. The site is 5 centimeter distal to the bifurcation to avoid injury to the posterior division of internal iliac artery. This decreases pulse pressure by 85%. So bleeding might stop. If failed or the patient is having unstable vitals or the family of the patient is complete, you will be moving on to subtotal hysterectomy. Leaving the what is subtotal hysterectomy? In total hysterectomy, you will remove the entire uterus. In subtotal hysterectomy, you will be leaving cervix alone. Even if this fails, you have to doing pelvic packing, umbrella pack, and parachute packing. What is angiographic embolization? It is done by intervention radiologist. The fertility of the patient is preserved. Many successful pregnancies have been reported after procedure done in stable patient. Aortic compression, that is also called as REBOA, resuscitate endovascular balloon occlusion of aorta. It is a temporary method along with mechanical compression manually above the sacral promontory if the abdomen is open. Above umbilicus if the abdomen is closed. Okay. Okay, this is the exam structure. First, we'll be writing the definition. What is the definition? It is, I told, the WHO defined a severe PPH greater than 1000 ml, and by convention, we say greater than 500 ml of blood in vaginal delivery and greater than or equal to 1000 ml in case of C-section. Clinically, we might call greater than 10% loss of hematocrit between admission and postpartum period. What are the types you have? You can divide into primary and secondary. Primary is less than 24 hours, and secondary is between 24 hours to less than 12 weeks. What are the types we have discussed? What are the causes? We have four T's, that is stone, trauma, tissue, thrombin. What are the clinical features? The clinical features are shock-like features, cold, clampy skin, vaginal bleeding, What is the management? And even you can add clinical features with hypotension of the patient, tachycardia. So it's basically shock-like features. What is the management? Initial step, you have to put two IV cannulas, give oxygen, call for help, uterine massage, and administer crystalloids, put Foley's catheter. After the initial step, you will move on to the medical management. What is the medical management? In medical management, you have uterotonics plus tranexamic acid. What are the uterotonics? We have discussed about oxytocin, methylergometrin, and the prostaglandins. Carboprost and misoprostol. What is the mechanical method? Mechanical method is bimanual uterine compression and then balloon catheters, that is Foley's catheter, Bakri balloon catheter. And what are the surgical methods? Surgical methods are beeling sutures. First, we'll do with beeling suture and then embolization. Embolization of the uterine artery, embolization of the internal iliac artery, and subtotal hysterectomy. These are the surgical options. What are the complications? Complications are shock, hemorrhage, and the patient might die. It is the most common cause of